So I am Bailey Maddox. I am a member of the South Carolina Board of Massage Therapy. I have no financial disclosures. Therapist education overlooks lipedema, both in basic certification courses and continuing education. And there is little to no discussion on how to address lipedema reduction surgery. When I worked with my first LRS patient, there was no readily available protocol to follow. So I developed this protocol using published research and practical application. We have been using it at my practice successfully with patients from different surgical centers. Manual therapy is essential both before and after surgery. Each phase of care has a distinctive focus, and the lack of post-op care increases pain, swelling, infection risk, and poor outcomes. Lipedema reduction surgery differs significantly from cosmetic liposuction. It is medically necessary. Procedures often involve high volume adipose removal, typically 5 to 10 liters or more per surgery, and surgeries are completed in stages. Most of the women that we have worked with undergo 4 to 6 surgeries, typically 3 months apart. And excess skin can be removed during a liposuction procedure or a standalone procedure. Surgery represents physical, emotional, and financial challenges. Patients often travel for surgery and return home to recover, and there are challenges securing surgery dates and coverage. And as therapists, we have to advocate for a multidisciplinary support system. This should include mental health professionals, registered dietitians for disordered eating concerns, and pelvic floor specialists, because the increase in weight increases pressure on the pelvic floor, and this makes it harder for the lower extremity lymphatics to drain. Pre-op care begins before surgery. It begins with conservative care. Many of the techniques used before surgery remain relevant after surgery, and some surgeons and insurance companies require a minimum 3-month trial of conservative therapies. But conservative therapy failure is expected, and conservative therapy does not significantly reduce lipedema tissue, but may impact pain and inflammation. Typically required therapies are manual lymphatic drainage, exercise, diet, and the use of compression garments. Manual lymphatic drainage, or MLD, is essential for swelling management and integral to post-op care. Teaching self-MLD early in the conservative care allows patients to be active participants in their recovery. And at each appointment, we confirm that proper technique is being used at home. While pneumatic compression pumps can influence lymphatic drainage, they should not be considered a substitute, but rather a support tool. Pumps are not appropriate to be used in the acute healing phase, while manual lymphatic drainage is appropriate. This is part of the reason MLD should be taught early, and patients should be confident in their MLD skills. Compression pumps should cover the torso to engage the central lymphatic system. And exercise should be modified for patient ability. Consistency is key. We encourage patients to find movements that they can be consistent with. 15-minute walks daily are better than a 1-hour walk once a week. And aquatic exercise is particularly beneficial due to the natural compression of water. Dietary support. Many patients struggle with diet-related trauma and disordered eating. Referral to a registered dietitian is advised to help develop healthy relationships with food. Nutrition impacts healing and inflammation. Diet should not be overlooked. Finding compression garments that fit correctly is a challenge. Wearing ill-fitting garments may impact skin integrity or have other negative impacts such as tourniquet effects. And patients may need to start with a lower grade of compression to build tolerance. The cost of garments should also be considered. Not all insurance companies cover compression garments for lipedema. We start patients new to compression in athletic compression. This gives us more options for size and fit, and athletic compression is easily accessible and economical. Once a patient is consistent with wear, we look for ready to wear in a Class 1 or a Class 2. Most of the women that we work with end up wearing a 20 to 30 with various levels of containment. We do not recommend custom garments until after surgery due to cost. After the final surgery, we recommend custom garments 6 months after surgery. Other therapies are beneficial. Myofascial release with holds of 30 to 90 seconds are well tolerated while still affecting tissue. Vibration, which can be in the form of a vibration plate or handheld device for pain relief and fluid movement. Handheld devices are easily accessible and are economical. This makes them great tools to use in conservative care with continued use in post-op. Cupping therapy or vacuum therapy helps to lift the tissues, and when used with light pressure, cupping therapy can be used to impact edema. Laser and light therapies, benefits are dependent on wavelengths, but can aid in healing and reduce inflammation. Pre-op begins once a surgery date is set. Ideally, we have been working with the patient prior to scheduling, so patients should be familiar with MLD. However, a review with a therapist is always helpful. We like to make sure that the surgeon's office has our information, and if we have any questions regarding recovery instructions, we ask. The patient is going to be responsible for informing primary care and securing wound care referrals, as well as ordering necessary garments and recovery tools. The most important item a patient needs is their compression garments, and we advocate for garments that patients can be compliant with. We also take into consideration if they will have help at home. Velcro wraps are one of my favorite tools. It is approachable for patients and their support systems to use, and patients are easily able to adjust fit throughout the day, ensuring compression is always provided. It is also easy to mix and match different products and different sizes for proper fit and compression. Velcro wraps also allow up to a 20% volume reduction before a smaller size is needed, and some Velcro systems are designed to be trimmed, eliminating the need for multiple sizes. If the patient is going to be wearing a bodysuit or sleeve-style compression garments, they should have multiple sizes on hand. Patients may not fit into one size range, so piecemealing different garments is going to be necessary. A fit test prior to surgery is beneficial, especially if the garments have complex zipper and hook systems. Now, we actually discourage open crotch garments. The lack of compression through the groin leads to genital edema and discomfort. Donning aids are helpful, and if patients have them in advance, they can practice with those aids. Other items include vibration tools. Our patients rely on handheld devices for relief from the post-op swelling. And then hygienic supplies like puppy pads or disposable bed covers to keep the recovery space clean. Antimicrobial soaps, bidets, as well as other tools to help with activities of daily living. Now, we prefer our patients to pre-book all of their appointments, including post-op, once they have a confirmed surgery date. All appointments are a minimum of 90 minutes with 1 hour allotted for hands-on therapy. 3 months pre-op, we're doing monthly appointments focusing on conservative therapies. 1 month pre-op, weekly MLD sessions. Our goal is to ensure that the lymphatic system is moving as effectively as possible. MLD can cause the lymphatic system to move faster for up to 3 days after a session. And by doing MLD frequently, we are speeding up the rate at which the lymphatic system moves, meaning more fluid can be removed. This decreases edema after surgery and decreases infection risk. Patients also need to be doing MLD on days that they're not seeing the therapist, on the weeks leading up to surgery. And then 2 to 3 days pre-op, we perform a comprehensive MLD session. After surgery, weeks 1 through 2, 3 sessions per week focusing on edema reduction. Weeks 3 through 6, 2 sessions per week adding fibrotic tissue management. Weeks 7 through 12, sessions are as needed, and we emphasize scar mobilization. Beyond 13 weeks, as needed care, with some patients benefiting for ongoing therapy for up to 18 months. Ideally, MLD done 5 times a week would have tremendous benefits. However, the barriers to care make daily appointments unrealistic. The middle ground that we have found is that daily self-MLD combined with MLD performed by a therapist 3 times a week greatly reduces swelling and post-op pain in the acute healing phase. Immediately after surgery, MLD should be resumed. Due to the sheer volume of lipedema tissue removed, aggressive techniques are not appropriate or patient tolerated. The largest concern is the increased edema. Edema puts pressure on the skin, increasing pain and sensitivity. Edema decreases immunity response, increasing the risk of infection. For MLD, we use every available pathway. Even though lipedema is not lymphedema, we do reroute the edema as if it was lymphedema. We use appropriate anastomosis and vasum vasorum. Patient should perform self-MLD on days not seeing the therapist. And MLD will increase urine production, so patients need to remain properly hydrated, using electrolytes as needed. Failure to be properly hydrated will decrease lymphatic drainage. Now, wound care is not in our scope of practice as massage therapists. However, we can monitor and refer out. Concerns can be related to either the surgeon or the local healthcare team. And swelling can change dramatically during this time. Most patients have nicknamed it swell hell because of the increased edema. Garments may need to be adjusted, especially if a tourniquet effect is observed or the garment is no longer providing necessary compression. This is why using Velcro wraps or having multiple sizes on hand is beneficial. Red light therapy during this time can support lymphatic drainage and decrease pain. Low-level lasers or other gentle tools can be used to reduce edema. Mental and emotional support. This is an incredibly important element. Having 5 to 10 liters of tissue removed is traumatic, and we cannot overlook the physical pain and the emotional exhaustion each lipedema surgery comes with. This is why a mental health professional should be part of the support team. Avoiding aggressive techniques like scar mobilization and fibrotic work is patient dependent. The increase in edema makes aggressive techniques intolerable. And while it may be appropriate to use scar mobilization techniques on smaller incision sites, generally speaking, the pain is not worth the benefit. There are techniques and tools to use for scar and fibrotic work that can be utilized when a patient is less taxed and skin integrity is no longer a concern. Skin integrity is important because at any sign of infection, the patient must stop wearing compression and receiving MLD for 48. So a patient must stop wearing compression and receiving MLD until 48 to 72 hours after starting antibiotics. This photo is of a patient who is 1 week post-op who did not receive any MLD, self or therapist. The red patch of skin was irritated due to a combination of factors, and the circled area developed a blister. The skin stretch required to perform MLD would have further irritated her skin. So in this case, aggressive techniques were not appropriate, and instead we focused on reducing edema. At home, a patient is going to be diligent with their recovery instructions from both the surgeon's office and ours. The elements that we emphasize are compression usage, typically 23/7 during this time, wound monitoring, and hydration. Handheld devices or handheld vibration can be used to reduce the pain. A massage gun is too aggressive. However, if that is all that is available, a folded towel between the skin and the gun will still affect tissue, but decrease the intensity felt. At week 3, we open up our full toolbox, using many of the therapies from conservative care, and while we're still doing MLD for swelling and pain, we're now combining it with other techniques. This is the time frame that fibrotic tissue or hard spots begin to appear, and at this stage, many of those hard spots are indicative of stagnant swelling. We use deep pressure holds of 30 to 60 seconds, especially for pitting edema. Myofascial release with 30 to 90-second holds, and for necessary traction, we use resistance bands and non-slip mats. There are a lot of other tools that we use, but of those other tools, foam makes the biggest impact. We have found that foam with negative space provides the additional compression needed to break down fibrotic tissue and still allows for fluid movement. Some designs are better tolerated than others. So we like to keep a variety on hand for patients to try, and there is a degree of aggressiveness with foam. One foam type, if it's no longer providing results, we can move to another more aggressive foam. and then even to cherry pits or pony bead options. If the patient has good skin integrity and has tolerated foam with the compression garments, we use foam with compression pumps. Pumps are at a low setting and for a short duration, no more than 15 minutes. The added compression of the foam with the pump is effective, but incredibly aggressive. And this is why we have opened up our full toolbox. We also don't forget the basics. We continue to check compression garment fit and monitor larger incision sites. By this time, smaller incision sites should be closed. Incision sites at the axillary may take longer to heal, and skin excision sites are not yet fully healed. At home, the patient continues their recovery instructions. We continue to stress the importance of hydration, and we encourage patients to reach out to us at any stage, but particularly during this time as they resume normal or modified activities. After the first 6 weeks, appointments are patient and surgery dependent. The surgeon may have only recommended 6 weeks of MLD, the patient may be returning to work, or there may be budgetary restrictions. We prefer patients to have at least weekly appointments booked through 12 weeks post-op. This ensures that we have the availability, and if the patient needs those appointments, we have them. We can also always cancel the extra appointments. The reality is that there are very few lipedema therapists, and we are the only ones in our area routinely working with lipedema and the only ones with LRS experience. Scheduling ahead makes sure that we can meet patient needs. At home, patients should have fully resumed their normal activities with some changes. Patients may have noticed newfound energy or muscles, or they might even be shopping for new clothes. As they return to their new normal, we ask that they wear sunscreen as fresh scars are sensitive to UV and to keep compression handy. Week 13. It has been 3 months since surgery, and it might actually be time for the next surgery. And while we reset our protocol, we address any lingering concerns. The most common issue that we see afterward is fibrotic tissue. And while this is often planned for in subsequent surgeries, we can still affect that tissue, and we consider that as we plan. Beyond 3 months, it all comes down to the patient. We may discover issues that will not be resolved with manual therapy, or other conditions that were masked by the lipedema. Patients may also need revisions, or patients may choose to go on for additional surgeries, such as skin excision. Or patients may want to just continue care for the additional support. Some of our LRS patients continued working with us well after a year post-op, because manual therapies provide additional relief. Long-term, those appointments are typically monthly. The healing process for each surgery can take 12 to 18 months, and emotional and physical challenges persist throughout the process. There is a poll for this session, and the patients who chimed in, nearly all of them said it took at least 6 months to recover, with half saying it took at least a year. So one of my very first LRS patients coined the term year of healing to describe this experience, and it was her way of trying to remain optimistic. As therapists, we also need to recognize the difficulty of this journey and not just the physical impact. Thank you.